and then you can start.
Okay, is everybody in? Ready to go? All right, so I'm Dr. Takenaka from the Department of Geriatrics. I'd like to welcome you to our grand rounds with Dr. Susan Christensen. A few introductory things before we get started. This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine at the University of Hawaii. At this time, in the comments, please enter the name, your name and your credentials for CME attendance purposes. So here in the chat. And as a reminder, we require evaluations for CME credit. You can find the evaluations by following the link in the chat or at any time on our University of Hawaii website for grand rounds, as well as to the email reminder that you got for geriatrics grand rounds. When you have comments on these evals, they're very, very helpful for us to plan our next grand rounds for the coming semesters, so that we can focus on what you guys want to learn about. And to disclose any financial relationships, all sponsors of CME are required to execute a conflict of interest policy, and they're expected to disclose to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. Dr. Christensen has disclosed that she has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So it's my real pleasure to introduce Dr. Susan Christensen, our second-year geriatric fellow. She's a family physician with over 15 years of primary care experience in Hawaii, and she realized the challenges that were faced by her older patients. She has an MBA in healthcare administration, and she returned to fellowship to learn about the best practices in geriatric care. She hopes to influence change within the medical business environment so that patients can afford needed services and doctors can earn a living, and the well-being of both remains paramount. So with great pleasure, I'll introduce Dr. Susan Christensen. Take it away, Susan.
Excellent. Thank you very much, Dr. Takenaka. Good afternoon, everyone. I am honored to be here with you this afternoon to share a personally and professionally transformative patient care experience with you. There we go. I'm accidentally muting myself. All right. For those in the audience not familiar with the Our Care, Our Choice Act, it is Hawaii's law authorizing medically assisted death. We are currently in the 4th year since the law went into effect, and it still remains controversial. My own perspective on the issue was shaped in my early career, highly influenced by Dr. Jack Kevorkian. I'm sure many of you have heard of him, who was portrayed as Dr. Evil. Needless to say, my perspective has changed, and getting to it was not a journey I was planning to take. So let's start by meeting Peggy. She was a vibrant widow who lived in her own home on the windward side of Oahu. Every time I saw her, she was dressed to the nines, complete with lipstick, matching handbag and shoes, and even a coordinating eyeglass chain. She was a philanthropist and was involved in her community, She lived a very healthy lifestyle, going to the YMCA every morning to swim her laps. She was on no medication. Her only diagnosis was pulmonary fibrosis, but this did not limit her activity in any way. Her greatest risk factor for disease were her age and the fact that she lived with a smoker for decades. Her first significant health concern arose when she was 90 years old. She had developed fatigue and a cough that lasted several weeks. Thinking it was a virus, and mind you, this was pre-pandemic, she did not come to see me until she started coughing up blood. Her chest X-ray identified a pleural-based mass which persisted even after we treated her for a pneumonia. A CT-guided biopsy was attempted, but the location was too difficult to be successful. After discussion of the best case scenario, which was that this was just a benign mass, and the worst case scenario, which was that it could be malignant, Peggy decided that she did not want to know more. She was not going to have any kind of surgery, especially after having that CT-guided biopsy attempted. That was more than she ever bargained for. And even if she did find out it was cancer, she was not going to do any treatment for it. She had already decided that. She was feeling fine, and she was back to her regular activities. I did not see Peggy much for the next year and a half, other than for her routine checkups. I then started getting ER reports that she was experiencing weakness, loss of appetite, back pain, and blood in her urine. Imaging did not find a cause for her hematuria, and she was treated for a UTI. When that did not work, she went back to the ER, at which point she was noted to be anemic. And then the third time she went to the ER, she actually required a blood transfusion. This is when I called her and asked her to come in to see me. Peggy was thinking that the hospital was where the testing needed to be done. So if she went there directly, she would get what she needed. However, I held the critical piece of information that the ER did not have access to, which was her undiagnosed lung mass. Once we put the two findings together, the needed test, a CT with IV contrast, was approved, and we found what I feared would be there, a very large renal mass. The day we met to go over her results, I was armed with options and next steps, but Peggy had her own ideas. After I told her what she already knew was coming, she sat back, smiled, and said, "Dr. Christensen, I have had a really good life." But what she said next took me by surprise. She said, "I do not want to suffer. Is there any way we can hasten this along?" Peggy was referencing Hawaii's Our Care, Our Choice Act, which went into effect January 1st, 2019, around the time we discovered her lung mass. So I suspect this was on the forefront of her mind the whole time. So this is a reference to Empathy 101, the throw pillow rule of thumb. I don't remember all of the platitudes I offered as to why her request for a life-ending medication was superfluous, but we have ways of controlling your suffering would have ended up on a throw pillow. Our Care, Our Choice was the 8th law of its kind to pass across the United States. 3 more states have been added since then, for a total of 10 states plus Washington, D.C., that now allow some form of medical aid in dying. To access rights granted by the law, patients have to meet these fairly straightforward eligibility requirements. They have to be diagnosed with a serious illness with a life expectancy of less than 6 months. They must be age 18 or older, be a Hawaii resident. They have to be able to take the medication independently. It can't be administered to them by another person. And they have to be physically able and mentally able to proceed through the legal requirements that have to be met to fulfill the prescription. We'll go over these next. All practitioners who may encounter patients with serious illness should be aware of these eligibility requirements, whether or not they are able to act as a certifying provider. Having the ability to openly discuss eligibility with a patient who may request information about these rights can facilitate appropriate patient-centered care. The legal requirements of Hawaii's Our Care, Our Choice Act are a little bit more complicated. First of all, the patient's medical record must contain documentation of 2 oral requests made to the attending physician and 1 signed written request. That attending physician has to accept responsibility for coordinating confirmation from a second provider and a mental health provider, completing all documentation and writing the prescription. Presently, only Hawaii licensed physicians, MDs or DOs, are able to sign as attending or confirming providers. A mental health provider can be a licensed therapist, including a licensed clinical social worker, PsyD, PhD, MD, or DO. At 20 days between oral requests, Hawaii has the longest mandatory waiting period amongst all 10 medical aid in dying authorized states plus the District of Columbia. The written request must be witnessed by 2 people, neither of whom can be part of the healthcare team, and at least 1 cannot be related to the patient. A minimum of 48 hours must transpire between the attending physician's receipt of the written request and writing of the prescription. So there are a lot of detailed barriers and limits and time constraints to this law. Back to Peggy. That first day when we met to discuss her diagnosis was when Peggy made her first oral request. This was in June of 2020. At the time, I documented it in her medical record, but I had no intention of being the physician who would see her through that journey. Ultimately, however, that discussion marked the start of the 20-day waiting period required by law and the beginning of our journey together. She was still ambulatory at this point and remained in her home. I referred her to hospice, which she welcomed, and they admitted her within the week. I thought, or maybe just hoped, that that would be the end to her request. Indulge me for a moment here as I pause our story to talk about values. According to life and business coach Tony Robbins, values are the fundamental beliefs that govern our lives. They are our inspiration to act, and they guide our decisions about everything. They embody the person we want to be, influencing how we treat others and how we interact with the world. Values are the core of who we are. As important as our values are in defining how we live, so too should they define how we die. When we are dealing with patients at the end of life, as providers, we have an obligation to consciously filter our own values and make sure that our recommendations reflect the values of those we are providing guidance to. Does this patient want to be alive no matter what that life looks like? Or does this patient want to leave this world if they are not able to return to their idea of an acceptable quality of life? We also have an obligation to be honest and provide perspective when it comes to a serious diagnosis. Is this patient realistic in their expectations for what can be done for them? Is this patient unable to see the good things that can still happen? I'd like each of you for a moment to reflect on your own values. And if you have already experienced or encountered a patient with an end of life prescription request, or what would you do if someone did approach you with a request like this? And try to filter it through your own values and what you think your response to that would be. And I welcome a discussion on that after the presentation. Okay, so back to our story. Thank you for that momentary divergence. I am embarrassed to admit that for 2 months, I did absolutely nothing for Peggy, even with regular updates from hospice reiterating her desire for a prescription. We were in the throes of the COVID shutdown, trying to figure out what telehealth was, but I managed to see her for a follow-up, and she made her second oral request in August of 2020. I still was not prepared to take on the responsibility for writing the prescription. Doing what I felt I could, I discussed options for supporting her and controlling her suffering. She was already enrolled in hospice care and had surrounded herself with supportive friends and family. Mental health services were difficult because of the pandemic, and Peggy was too ill to attempt attending a support group. She was not a religious person and did not desire pastoral care. For Peggy, her choice to continue moving forward with medical aid in dying was about remaining in control of her mind and body, maintaining her dignity by being able to perform her own personal care, and avoiding suffering. She was very pragmatic and decided she had nothing vital left to contribute to this world. She was ready to die on her own terms. So here is where I found myself. My patient was asking me for help, and even though it was legal and within her rights to access a prescription to end her life, I did not think I could be the one to write it. Yet, this was not something I could easily refer her on to another provider for. She was way too far along in her disease process for that. I felt like I was abandoning Peggy in her greatest time of need. So we all do things in medicine that cause us moral distress. We do it all the time. Sometimes it's for our employers. Sometimes it's for the insurance companies. Sometimes it's for the government. And sometimes it's for the patient. In order to continue doing our important work, we have to find ways of making peace inside ourselves. When it came to Peggy, I was able to come to the realization that what needed to be done was about her It was not about me, but I was the only person who could do what she was asking for. And so I joined Peggy on her journey. Having established that, it was up to me to figure out the way. Unlike Kaiser and Hawaii Pacific Health, where there are dedicated program coordinators for assisting patients and their providers through the process, there was no support from within the practice I was part of at the time. I was on my own to figure this out. The medical record documentation was the easy part. It was very straightforward. I had already done that part by documenting our conversations together. I then had to seek out a mental health provider and a second confirming provider. And that required me cold calling other doctors who had been part of her care up to that point and asking them if they would provide that documentation. These are the helpful resources that I came across in my journey. I would like to give a shout out to Kokua Mau in particular. If you don't know about Kokua Mau and everything that they do to support people who have serious illness, those who care for them, and those who work in the field every day, I strongly encourage you to check out their website. I would specifically like to thank Jeanette Kojane, the executive director, who personally spent time on the phone with me, listening to my struggle and directing me to resources. The Department of Health website, also listed here, provides a roadmap and all of the forms necessary to comply with the law. Think I went, there we go. Sorry about that. I clicked on the link. Sorry about that. Technical difficulties. Not sure how to skip ahead. What's there? Come on. I know we're gonna have to go through each of my pictures again. This last one is my doggies, though. Those are my little angels, my brindle babies. Okay. So here's the list of forms from the Department of Health website on the left side. So as you can see, there's quite a number of forms there. And then on the right is an example of the final attestation statement by the patient. So this is the form that the patient completes within 48 hours of consuming the medication. And all of these forms have to be submitted to the Department of Health for documentation and their record keeping. So here we are, back to Peggy. So we had completed all of the consultations, the forms, and the documentation that we needed to by the end of September. And I was ready to write the prescription for her. We located the pharmacy that she would be getting the medication from. And for the first time in the entire process, Peggy balked when she learned the cost of the medication would be over $400 and it was not covered by insurance. It actually took her another 2 months to come back to me and ask for the prescription to be written. It is useful to know that for some patients, there could be a prohibitive cost involved. And this is best if we can discuss this with our patients up front in the beginning of the process, because if money is going to be an issue for them, we want to help navigate that limitation early on. So she came back to me in December and asked for the prescription to be written. There is a protocol that is used for the prescription. The orders have to be ink signed, so we can't fax the prescriptions in. And then the patient has to show up in person for counseling with the pharmacist before they can take the medication home with them. So there are a lot of final steps that had to be taken there in those last couple of days. Peggy did take the medication on the very day that she picked it up from the pharmacy. So here we have the statistics for the state of Hawaii for the first 3 years that this law has been in effect. 2019, there were only 13 providers who participated with writing prescriptions. In 2021, we were up to 21 providers. You can also see that the number of prescriptions written has increased over time, up to 70 that were written last year. And then the number of patients who died for whom a prescription was written, and this does not necessarily mean that they took the prescription, but that they died after a prescription was picked up. Those numbers have increased. And then in our last column, you can see how many have been recorded to have died by taking the medication. So in 2021, we had 70 prescriptions written, but only 29 patients actually consumed the medication. There can be a lag in this final statistic because the prescription may be written in 1 year, and then the patient holds on to the medication and doesn't take it till the following year. So there can be a lag here after that first year. So just to be aware that this number can change moving forward as the documentation comes into the department. And here is the distribution of prescribing providers across the islands. And this is one of the limiting factors for obtaining medication, which is that some patients just don't have access to a provider who is able and willing to write them a prescription. There is a concentration of providers on Oahu, but you can see, certainly Kauai, they didn't have anyone who was willing to write a prescription until last year. And then the Big Island only has 3 and Maui only has 3. So accessing this option is difficult for patients. So there are future directions for patient advocacy. There have been bills in the State House and State Senate to propose changes to the law to authorize mid-level providers to be able to serve as attending physicians as well as consulting physicians. And then also to authorize psychiatric mental health nurse practitioners to serve in the role as a mental health provider. Also requesting a reduction in the mandatory waiting periods. That 20 days is extraordinarily long for someone who may be with less time than that to live, and patients are dying before they can get through the process. Unfortunately, this year, neither the state bill nor the House bill went to a final vote in the 2022 legislative session. Presumably, they will be reintroduced next year, and hopefully we'll make some headway, but they were not voted on this year. And then we just need to continue public education about the law and what we're doing here today, making more providers aware of what the law is and how they can help their patients. So that is all I have for you this afternoon, but I am very open to taking your questions. I'm quickly looking at the chat. And I'm seeing from Dr. Stewart from the Department of Psychiatry. Oh, thank you. Thank you. So Dr. Stewart, you have been part of the certification process for several patients. Would you mind speaking on your experience?
Well, I started off because there weren't any providers. And this was one of my best friends, who was an emergency room physician from California, was a real leader in California about the aid in dying. And so he got me into this several years ago. And here in Hawaii, we're still trying to build a network of providers. If we would have known each other, which I know we didn't at the time,
No.
I could have helped you at several points in when you said you felt you couldn't do it, which is fine. I'm not challenging anyone's personal morals.
Mhm.
But at that point, my sense is that then we should refer to a patient, to a provider who may be able to help the patient. So at that point, you might have referred to me or another provider who could do that. And we might have helped this lady, your patient. You gave a very wonderful presentation about her.
Thank you.
Could have addressed her suffering well prior to when she eventually took the medication. So
Yeah.
I think the main reason Dr. Takashita sort of gave me the heads up on this presentation today, and I'm so glad I was able to attend.
Thank you.
And so I just would like to volunteer to be a contact person for you, both from an attending, a consulting, or a mental health provider, because I am a psychiatrist, but I can fulfill all roles. But I have personally gone through a transformation in doing this work. Been doing it now for over 2 years. And initially I had some reluctance, as you described. But
Yes.
after doing several, I'm not going to try to sound Pollyannish, but it's one of the most beautiful things when a person chooses to end their life on their own terms. Terminally ill patient who's has, cognitively intact. I've been to so many different deaths where there's parties, people are singing songs. There's also people that would rather not have that type of end, but I would just really encourage as many providers as are out there to consider this as this has been a transformative experience for me as a physician. It really gets to the core of what we try to do for our patients, which is one, to do no harm and to help them. And this is the ultimate in helping a patient, in my view. And I don't want to keep going on and on because I could, but I won't.
Yeah. Yeah. I agree with you. And at the beginning of my journey with her, there was no network of providers to refer to. In the very beginning, that is what I was trying to do is, okay, how do I find her somebody willing to write the medication for her? And that's when I came across Hawaii Pacific Health and Kaiser, but if you're not a patient within their network already, it's very hard to get into those systems. So yes, if we can get a broader network of providers willing to participate in the process, I think that would be wonderful to make it a simpler journey for everyone.
I would suggest, I've been trying to establish a clinic, a medical aid in dying clinic here at Queens, but have
Okay.
got a lot of pushback, and that's all I'll say about that.
Yeah.
But I think a type of clinic like this, with those physicians who wish to participate, would really be a service for our patients here at Queens. And I'm still not giving up on establishing some sort of home base for a clinic. So if geriatric wants to do that, you can count me in. I'll help you out as much as I can.
Okay. Yeah, I can't speak for the department.
I understand.
Yes,
Yeah.
yes, it is obviously still a delicate and controversial issue for a lot of people. So yeah, I think that it's going to take a little bit more of a individual approach to it. Yes. Thank you, Dr. Stewart.
Oh,
I
my
appreciate your.
pleasure. And I look forward to hearing from you. Hopefully we can get some collaboration going here to help you out in the future.
Thank you. Okay, so I'm moving on through the chat. Rachel Porter, you asked, was I in attendance at Peggy's death? I was not. I spoke with her the morning that the pharmacist provided the medication to her, and she made it very clear that that was going to be her last day, but I did not attend. In terms of what I heard about her death experience afterwards, I know that her family members were not fully supportive of it, that she was more surrounded by her friends. And so, I do feel a little conflicted about that, but I think that's my own values playing in there, that I would not want to die without my family members there. And so yes, I still have some internal conflict about exactly how things proceeded with her. And then Dr. Chong, do I know if any of those assisted deaths occurred for patients? Yes. So assisted living and nursing facilities specifically do not allow the medically assisted death, that these do have to occur in private homes. And there have been lawsuits on the mainland with regards to that. And I suspect it has something to do with federal funds and the possibility of the influence of the healthcare team on the process. So no, I don't believe that patients who live in assisted living or nursing homes would be able to consume the medication on those locations, that they would have to take the medication elsewhere. And maybe Dr. Stewart or Jeanette, maybe one of you has more information on that topic.
In regarding nursing care, skilled nursing facilities, you're right. They don't allow the actual consumption of the medications on site. So what I have done is the families have moved the patient home, and then they consume the medications there. And just one other point, I always offer to be there when the person consumes the medication. And out of all the cases that I've worked, only one has turned me down. And I think we could really provide that final support to patients. But again, that's just my practice.
Mhm. Excellent. Thank you. Yeah, so Jake, I think that answers your question as well. Um, so Dr. Morita, who was in attendance, so she had her at least 3 of her friends were with her, as well as actually no, I correct myself. The hospice nurse was not present. The hospice nurse came afterwards, but also knew that she was going to be ingesting the medication that evening. So she was surrounded by friends. And oh, so Jessica Ackerman, so yes, you have a very challenging question here. Are quadriplegics with a new terminal diagnosis excluded due to their inability to self-administer? And uh, as the law is written now, I believe that they would be excluded because they can't self-administer the medication.
And again, not to interfere with your questions,
Uh-huh.
but I've helped maybe 3 or 4 ALS patients
Mhm.
and other patients who couldn't physically hold the cup up to their lips. So what I have done in that case is put a straw in the solution and held the cup for them, and they sucked down themselves. And I consider that self-administration. So therefore, a quadriplegic could theoretically self-administer by having someone hold the cup with a straw.
Okay. Yep, because then they are intentionally,
Yes.
okay, thank you. So is it required that the patient ingest the medication within 48 hours of receiving it? No, no. So there has to be 48 hours from when the patient signs their written request. And then and getting the prescription. So they give me their written request. If everything else is in line, then 48 hours I can write the prescription. So that final 48 hours that we're talking about is their final attestation statement. So once they sign that and say that, yes, I intend to take the medication, they must consume it within that 48-hour window, or presumably do a new attestation, when they are ready to do it. So no, there are no mandates that they take the medication at all. It's only about getting access to the medication. And then and I'm sure there are cases where patients consume the medicine and forget to fill out that final attestation. And really what that does is, makes it more difficult for us to complete our statistics and reporting information on what has occurred, but no, there is no mandate regarding taking the medication. And does the authorization expire or need to be renewed? To my knowledge, no, that once the patient has the medication, they can hold on to it indefinitely. Now, the idea is that the patient has a limited life expectancy. As we all know, some patients end up doing better than we expect and might live longer than that 6 months, especially if they are receiving good quality care and support through hospice. But I do believe that no, that there is not any requirement to renew the process. All right, excellent. Anyone else want to talk about their own experience or? I'm open to alternative perspectives and So Dr. Orsine, great question. What medication was given to aid in dying? So just prior to the presentation this afternoon, I was going over it with my husband and he asked the same question. There is a protocol that has been vetted by a lot of the medical aid in dying providers on the mainland, especially in Washington and Oregon, where they've been doing it for a number of years. It is a cocktail that starts with antiemetics, followed by anxiolytics, and then followed by the terminal cocktail, which contained an opioid, amitriptyline, and digoxin. The pharmacies have the protocol, the pharmacies that participate have the protocol on file, but figuring out how to actually write the prescription did take me a little bit of effort to get to who could fill the prescription and what the prescription would entail. But yes, there is a protocol, and the protocol has changed over time as side effects have been noted or failures. I believe there was a failure in Hawaii last year that was reported, where the person consumed the medication and didn't pass away as expected. Has there been feedback regarding how long it took for the patient to die after ingestion and any untoward effects? So for my patient, she passed away quite quickly. It was within an hour and a half after she consumed the lethal cocktail, and she was very peaceful, according to the family members that were, the friends that were with her. But yes, Dr. Morita, I have heard of dramatic episodes, and problems. And some of that is patient factors, and, some of it might be that they didn't consume the medications in the proper order. But yes, that is part of the informed consent process with the patient, that, that can happen. So Jake Moore, excellent question. What do you need to put on the death certificate in these cases? So we do not put medically assisted death. The diagnosis is the terminal diagnosis that that they were given for that 6-month life expectancy. So for my patient in particular, we put renal mass, presumed renal cell carcinoma, and that was her cause of death. Great question. Yes, so the only place that the ingestion of the lethal medicine is documented is in the patient's medical record, and then with the state for legal purposes. You're welcome. Excellent. Anybody else have other questions or thoughts? Jeanette, are you on? Did you want to say something? Hi, Jeanette.
Hi,
Thanks.
Susan. Nice job. Thank you so much for sharing, and thanks for, giving some of your thought process that helps also help fellow physicians understand that. And thanks for the shout out to the Kukuama website. That was unsolicited, but of course, very appreciated. And I hope people know that Kukuama is a repository for all sorts of information, advanced care planning, post listings of where hospices are. So resources also for families on bereavement and grief. So we really hope people will take advantage of our resources, and people can certainly contact me. One of the things that I think is so important is, and one of the recommendations that our Department of Health made early, that people really should be enrolled in hospice. And I think that that's such an important thing to remember. When people ask about this, well, as you've shown, this is never a short conversation, but so much of what we do with serious illness is not a short conversation, which is, what most people would like. So when people are asking either for themselves or someone else who is really suffering, hospice can be there in a matter of hours. So hospice really is the first go-to. And I think that that's so important for people to be thinking about. So you can, and again, also, as you said, whether or not somebody moves forward with the Our Care, Our Choice Act, hospice can be there today, helping with not only the physical suffering, but the emotional and spiritual suffering that people can have. So I think that that's such a really important message to people, and for people who have patients who are coming in that last 6 months of life. And again, the diagnosis is the same, right? Of 6 months to live. Well, you should be calling hospice right away. So I really appreciate that part of it. And if people wonder where the hospices are, if providers aren't sure how to find hospices, they are all listed on the Kukuama website, and there's links to them. And again, the hospices will be there relatively quickly and are happy to talk to providers as well as family members about what services they are able to offer and how they can help, especially with the immediate distress that people may have. So again, I hope people can visit our website, and I hope that people can find whatever resources they're looking for. So thanks again for your presentation, Susan.
Yes, you're welcome. You're welcome. Thank you, Jeanette. Okay, a couple more things are popping up in the chat here. So Dr. Morita, if patients are not ready for hospice quite at that time, if they meet palliative care criteria, they can also start a palliative care consultation. Absolutely. And concurrent care as well. So it's kind of that foot in the door for hospice, because a lot of people do find the word hospice scary. Though usually the patients who are looking at accessing Our Care, Our Choice are not those patients that are hesitant towards the hospice. So, but excellent point. Thank you. Wonderful. So it looks like we have about five minutes left to go. Does anybody else have any thoughts or comments?
So I can also build on what Naomi, Dr. Morita is saying. And again, I can send people, if you're interested in what palliative care is, and especially as a provider, and this may be a very well-educated group of providers. Obviously, you called in on the topic, excellent. I will say some of your colleagues do not yet know what palliative care is or what hospice care is. So I hope that people can take an opportunity to understand what the opportunities are for both of those. And, I've been in this field for a long time, and I've never had a family or a patient say, wow, I'm sorry that I called. Everyone says, why didn't I call hospice earlier? Why didn't I ask for help? So, so I think that's important. And palliative care, as Naomi says, there are different names depending upon the type of health plan that you have. So it's really something to look at. And our website has all sorts of good information for families and patients who are looking for information about palliative care, as well as providers. So we have, if you put in Kukuama plus where do I find palliative care, then that is there. So I really hope that people understand more about what what palliative care is and how to access that.
Absolutely. Absolutely.
And we did a presentation earlier this year. There were 2 presentations about what the VA is offering. So again, you can't access Our Care, Our Choice Act if you're, through federal funds, but they really have just a wide range of opportunities to take care of people who are very sick, and will also what they're able to do at home. So that's really important to understand what the VA has. And then both UHA and HMSA have good programs. So, but I don't want to talk over Dr. Blanchette's question about religious people. I don't know if you know the answer to that.
I do not know the answer to that question. I would imagine it depends on the religious background of each of those providers. Most likely Catholic priests would not be in support of this.
Right.
And coming from a Catholic background myself, but I'm sure there are other pastoral care providers who would be willing to be there and support their
right. And
community.
I think that's one of the, again, if you're enrolled in hospice care, an important part of the hospice team is a chaplain or a spiritual support. So again, it would be that every individual provider can choose whether or not they're going to participate in the Our Care, Our Choice Act. But if you're, an integral part of what hospice is able to do is to provide that spiritual support. So again, that's one of the good things about being in hospice care, is that it's not only the physical symptoms that are covered, but the hospices look at the emotional and the spiritual support as well. So, but you are, I think you are absolutely right. The Catholic Church is very opposed to the medical aid in dying. And then I think it depends on other people's approach. So in terms of getting good emotional, spiritual support for patients who are coming to the end of their life, and the support for the family, that's where the hospice can really be helping out.
And so thank you so much to Dr. Christensen and everyone who participated in the discussion today. We'd like to wrap things up and remind everyone to please fill out your evaluations and just give us suggestions if you think of anything else. Thank you for attending today, and thank you. Great job, Susan. We'll see you guys next month.
Thank you so much, everybody. I appreciate it.